Good morning, everyone, and welcome to our Corrections 201 virtual learning event. I am Cassie Sturtz, the Health Program Manager here at CareOregon, and will be walking us through our event this morning. Okay, a little bit about our agenda this morning. So we are going to do some brief overview, just looking at jail versus prison, kind of getting into what is it and what's the differences between the two. We'll spend a little bit of time talking about services available to folks while they're in custody in a prison here in the state of Oregon. We'll talk a little bit about our release planning services and Department of Corrections and what that looks like. And then we'll head into some Q&A this morning. Some of our learning objectives. So we're really working to understand what's available to folks, understand what release planning looks like, and understand how the folks who might be in attendance this morning could support folks during their transition back into the community from incarceration. So like I said, let's start a little bit with kind of like what is jail and what is prison? So jail is kind of really a holding space, right? So it's a space where folks who might be accused of various crimes under federal, state, city ordinance are being held. In Oregon, the majority of our local jails are operated by the county in which they reside. Prison, however, is for those who have been convicted of certain crimes. And in Oregon, our state, or the Department of Corrections, operates our prison system. To give you an idea just about length of stay in jail versus prison, we've got a couple numbers at the bottom. So you'll see in the metro area in Multnomah County, an average jail stay hovers around 5 days. And in Oregon, an average prison stay hovers around 69 months for folks. So just to give an idea about the unique circumstances that folks might be facing or how different a transition might look after a long-term incarceration in prison. On the screen, you'll see a map of where our DOC facilities are across the state of Oregon. This is just to give you an idea about where our prisons are and to give you an idea about some of the names that you might hear. And of course, the Department of Corrections website has lots of information available, and we just wanted to provide you those links here to give you some ideas about how you might explore some additional information. Okay, I'm going to hand it off to Christy Hutson, who is going to present this morning, walking us through the Department of Corrections services that are offered to folks during their incarceration. So, welcome, Christy.
Good morning, everyone. We have a pretty extensive administrative team that runs our Oregon Department of Corrections Behavioral Health Services Division. And our Behavioral Health Services Division includes mental health and substance abuse disorder. And as you can see on the screen, Donnell is our administrator. Dr. Dravis is our chief of psychiatry. I am one of 3 assistant administrators. Ms. Guinness and myself are we take care of the mental health operations, and Meredith, she oversees our substance use disorder treatment services. And then we've added Ms. Katie Bell as our clinical manager, and she keeps us up to date on our policies and procedures. And we have started a student intern program. And so she's in charge of that. And then sometimes we get clients from Oregon State Hospital, and she navigates AIC's transition in and out of OSHU and back to us. Okay, so we'll just start off by the first day we call them adults in custody, so it's AIC. When they enter our intake center, it's at Coffee Creek. And what that happens on the first day of their arrival is they are screened by a nurse. They come to the prison and release in R&D, it's release and delivery, and because that's where people come and people go. They go through this specific part of the prison. to get specific services as they're coming and going from prison. And then within 1 day, a qualified mental health professional will screen the adult in custody to make sure they don't have any mental health issues. And if they do, then they are given a diagnosis and they are sent to a prescriber if they need medication. So that happens all at intake for the mental health. And then there's a TCU drug screening is completed. And what it does is generates a sub-score to indicate if they might need treatment or not. And then also what happens at intake is guys are probably there for like 30 days. And sometimes they'll have other issues that come up, not just from the first time they're seen. And they can ask their unit officer if they can talk to behavioral health services, or they can write what we call a kite. And what it is just a communication form that goes to staff, and they then are triaged within 1 working day. And it can be from the client, or it can be from staff, or like anyone that has some concerns about them. So we get referrals from nursing, doctors, like just anyone that comes into contact with them. They also will be given an informed consent, and this is something that whether they agree to treatment or not, if they have a mental health diagnosis, then we still follow them and make sure they're okay. We don't put them on call-outs and make them come if they don't want that, but we follow them. We will follow up with like their housing unit officer to make sure they're okay. And then anytime during their stay, not just at intake, they can be referred or refer themselves to BHS for mental health treatment and or substance abuse treatment. All of our institutions, and I think Cassie showed you a map of all our institutions. All of our institutions, with the exception of Warner Creek and our our South Fork Forest Camp, they all have behavioral health services available to them. So what we offer is individual therapy, case management, the individual treatment. We also have some therapists that can do EMDR. And then we have medication management by either a mental health nurse practitioner or psychiatrist. We also have group therapy, and there just is several different types of group therapy, ranging from like cognitive behavioral stuff to dialectic behavior therapy. There is a lot of different stuff, and we also have some that are specific for women. So we try to have a great big choice of different kinds of programming that we can offer them. So depending on what the population needs, we can meet their needs. Wait, sorry, I am not very techy. So part of our ongoing mental health care is we do individualized treatment plans. The qualified mental health professional meets with them, and within 30 days of them meeting with their assigned QMHP, they will develop a treatment plan with the client. And our treatment services are based on mental health codes, which come from diagnoses, and then their levels of functioning, which is how they're functioning within the prison setting. And then in our system, to be seriously mentally ill, it's based on a combination of your mental health code and then the levels of functioning. So for example, an MH3, which is somebody who would have schizophrenia or major depression or bipolar, those kind of folks, if their levels of functioning, and it goes from 1 being the least severe till 5 being the most severe. If they are anywhere from a 3 to a 5, they're considered seriously mentally ill. So that's kind of like we do this combination. And then an MH2, if they are anywhere from a 4 to a 5, they're considered seriously mentally ill. And kind of what that equates to is if they're found in violation of committing like a rule violation within the correctional institution, then they get some special considerations if they are seriously mentally ill, depending on the level of their functional impairments. We also have crisis services at every institution, even at Warner Creek and South Fork Forest Camp, and how they're handled at those places. If they ride a kite or the nurse feels that they need to be seen, they're seen through televideo, and then they're sent to a institution if they need services. The other institutions, their crisis services is that's one of the QMHPs has a radio, or at some places they have phones, and if staff or if the AICs are in a crisis, they're like going to self-harm or something like that, something very emergent, we see them right away. Another way they can be seen is they can write us a communication form, which we call a kite. And then if they have put any kind of symptoms in those kite, we see them the very next day in our mental health clinic, which that's just a triage to make sure they have upcoming appointments. And if they don't, maybe to get them appointments or just to make sure we're responding to their concerns. Sometimes it's just helping them remember some coping skills, but it's just a real quick, maybe 10 or 15 minute interview to triage them. We also respond to sexual assault or sexual harassment. We see the clients that this happens to immediately. Also, there are questionnaires when they first come into an institution at R&D. When they receive them, they give them questionnaires about if they've been sexually assaulted or anything in the past, and they can and if they have, then we see them, we get notified and we see them within 14 days. So we really take sexual assault and sexual harassment super serious in the Department of Corrections. And then if anyone, like why someone would be sent to a segregated setting is if they had a rule violation that security felt made the institution a risk for safety and security. They send them to a place called disciplinary segregation. And then within 1 day, if they have a MH2 or 3 code, they are seen by a qualified mental health professional and assessed. Okay, I kind of talked about mental health clinics. We also, there are also multidisciplinary teams within the Oregon Department of Corrections, which consists of security and correctional counselors and nursing. And what happens is we all go and talk about people that are struggling within our department and how we can sort of help them. Also, we review people that have been in disciplinary segregation 30 days or more. And what we usually do in those settings is that sometimes they vote to send somebody to higher levels of disciplinary places. We don't vote on them. We just try to give information that it would be detrimental to someone's mental health, or that person could handle it, or maybe reasons why they might have been confused or something and been paranoid and thought that somebody was talking about them, which led to them attacking them. So we help in those sorts of situations, help people understand people's mental health symptoms and try to help them get the appropriate care they need to reconstitute. So we have higher levels of care. We have general population, which is our lowest level of care. We have mental health housing. We have DTU, and then ICH, and ICH is intermediate care unit, and DTU is a day treatment unit. And then we have the mental health infirmary, which is like an inpatient psych hospital. So those are all, and we kind of decide on by the way they're functioning, which level of care they need. And the QMHPs kind of, because they are the ones that are seeing them on a regular, consistent basis, they decide kind of where they need to be, and then they make referrals accordingly. And then we also coordinate with outside providers for things like gender dysphoria and specific care needs. We're also expanding. We're in the middle of trying to set up a neurocog unit at one of our prisons. So we'll be coordinating with people that know more about that specific thing than we do. So we really try to get others involved if there's a specific need for any AIC. And then I kind of talked about the ODOC and OSHU relationship, but PSRB, sometimes we will need to give, we don't go to parole hearings with people, but if the PSRB asks us for information and the client agrees, then we share that. We also have a pretty robust release planning. We have one release specialist. She does civil commitments when needed. She also, just like our top most sick individuals that might need a group home or Social Security, those kinds of, real sick people, she'll do release planning for them and make sure they have somewhere to be housed when they're leaving, and mental health treatment. So our highest treatment need codes, these are our mental health codes, are DD3s and MH3s. And then the next level is DD2s and MH2s. And like DD2s or MH2s will be people like with depression or PTSD, like a generalized anxiety disorder. The moderate treatment need, the MHRs, those are folks that might be in crisis, or what they just really need is like medications to keep them stabilized, like somebody that has an adjustment disorder or just a anxiety NOS disorder. And then the MH1s, we have seen them. They could benefit from treatment, but we just don't have the resources. But they can kite or anything if they are having a hard time, they can do the crisis services. And then the MH0s means that they have been evaluated and have been found to not need any sort of treatment. And then, like, we talked about the levels of functioning a little bit, and this is how we determine how often they need to be seen. So the level of functioning 5, which is the most severe, they are seen every 7 days. And those are the folks that if they have a hearing, we would write a hearing memo, and they would not be responsible for like fines and things like that. They might still do segregation time, but it would be probably in a different setting than disciplinary segregation, probably if they're very ill in the mental health infirmary. Then the LOF4s are seen every 7 to 45 days. These folks are pretty impaired, and they benefit from a lot of support to avoid them going into crisis. Then an LOF3 is seen every 46 to 90 days. These folks they need some support, but they're pretty independent. They'll usually have jobs like cleaning or working in the kitchen, things that aren't too intense, but just will keep them busy. And then they will usually go to day rooms and go out to yard, and they do all that stuff pretty well without support. They still do need some support, and we still do treatment planning with all of these levels of functioning. Then the level of functioning 2, they're seeing every 91 to 120 days, and they're more mild. They'll have jobs, like maybe being peer mentors to other folks or in the industries. Same with LOF1s, they're seeing every 120 to 180 days. These are people that are extremely stable. They just probably need somebody to check in and make sure everything's still going okay. All of these folks can reach out to crisis at any point in time if they're having crisis, but yeah. So all of them may engage in group services despite their level of functioning. And then, and this is just how often their assigned QMHP will see them. So keep on going on. So I kind of went over this before. So those are that's our level of, and I didn't probably speak about the behavioral health units. So that is a unit, and we have one for the women and the men. And it is a unit where people that they're severely mentally ill and they've committed like rule violations, like getting in fights where they hurt someone really bad, or like it's like the top 5% of the most dangerous things that you could do in prison to get in trouble. And so if they are severely mentally ill, rather than sending them to its intense management unit, which is more segregated time where you're kind of by yourself, we send them to a behavioral health unit where they learn skills to manage their mental health, because we are finding that those two things are tied together. Like sometimes their mental health, it's a part of them having these behavioral problems in prison. So we're on to substance abuse disorder. There are 2 different kinds of programs. One is alternative incarceration program, and then the other one is non-alternative incarceration programs. And the selection is determined by the treatment assignment and screening committee. So they decide, and it's kind of based on sentencing, and referrals come from correctional counselors. And then they look at their treatment need, their program qualification, their medical and mental health clearances, and how their eligibility window. So AIP, the alternative incarceration programs, they offer time cuts, but the non-AIP does not offer time cuts. And depending on their sentence and other factors, some qualify for time cuts and others don't. So people are placed in these programs based on like the time they have remaining on their sentence, and then available bed space is also another factor. So we have 3 contracted treatment providers, and they are, the 2 of them, the Powder River and Columbia River, they're in minimum institutions, and Oregon State Correctional Institution is in a medium. So these programs, they're certified outpatient programs, and they all have professionals that are CADC certified. They're for the last 6 months of a person's custody, and they have individual and group counseling as a part of them. And then they do discharge planning with community partners for aftercare. So we try to make sure there's like a seamless in all our treatments. Then there's ODOC. We actually have some treatment providers that work directly for the Oregon Department of Corrections. The first one is at Coffee Creek, and we have a certified outpatient treatment. And the services for our programs are provided by qualified mental health professionals and CDAC professionals. We also have peer recovery supports available for our clients as they need them. This program is for the last 180 days or last 6 months that they're in custody with us. They also offer group and individual therapy. And they also have discharge planning with community partners for aftercare. And probably we often call on some of you all that are on the training today. So our other BHS, Oregon Department of Corrections treatment, is at Columbia River. And it's a co-occurring disorder treatment. It is really amazing. It's for clients that have mental health needs and substance use disorder needs. And it is also a certified program from the Oregon Health Authority. And it's residential. It's a residential setting. And services are provided by QMHAs, CDACs, and QMHPs. We also have peer recovery mentors in those. And this program is for your last 9 to 12 months in custody. They offer individual and group counseling. Some of them, they also have the ability to do EMDR with people because some of their treatment providers are trained in that therapy. They have in-depth care coordination and discharge planning with community partners for aftercare. These folks also do extensive treatment plans and includes the client. So the client is always knowing and driving their treatment. And we have a couple of outpatient chronic disease model treatment for folks. And these are offered at Coffee Creek and Oregon State Penitentiary, and then Snake River Correctional Institution. And these are all outpatient services. They use a chronic disease model approach. It's a voluntary program, and they can be eligible for this at any point of their incarceration. Services provided by the QMHAs and the CDAC professionals. We also have peer recovery mentors that might help if someone is in crisis, not like suicidal or anything, but just is having a rough day and needs somebody to talk to. Individual and group counseling. They do all of that. And then we help them make plans for long-term recovery management. And then if they're near release, we also provide transition planning support for people. But we'll have some people that are lifers that take advantage of this program. There's some that are doing long stints, and it's in the middle of their program because it's important for them to have treatment no matter what part of their incarceration that they're at. Right, well, I think at the end we're going to do questions. So those are all our numbers. So if you need to get in contact with any of our admin team for any help with people that you have gotten in the community and might need some information or whatever we can do for you, we'd love to partner with you. And I really appreciate being able to have time to talk with all of you and for CareOregon inviting me to speak. Thank you so much, and I look forward to all your questions.
Thanks so much, Christy. And thanks to folks who popped their questions into the Q&A box. We'll bring all our presenters back at the end to answer some of those live with you.